And in terms of the drugs that we use, when we induce ovulation, obviously we use drugs, right? Like gonadotropin, or in assisted reproduction treatment, we also use gonadotropin to hyperstimulate the ovary in order to get the eggs. So obese women actually is well known to respond less well to the drugs used for ovulation induction or ovarian stimulation in assisted reproduction. Basically, this is related to the volume of distribution. If she's obese, she has a higher volume of distribution. So the effective dose of the drug that reaches the ovary would be much less. And she needs a higher dose, the cost would be higher, and the response would be slower. And weight reduction actually may improve the response to ovulation induction. Once she gets pregnant, there's still problem if she's obese. PCOS women who are obese have increased rates of miscarriage, either talking about natural conception or the conception from ovulation induction. Okay, so they have a significantly higher risk of miscarriage compared to those with normal BMI. And if she survives the early pregnancy, attains an ongoing pregnancy, right? In the later part of the pregnancy, if she's obese, she will also be subjected to a higher obstetric risk. So that's why weight reduction before a planned conception is important, so as to reduce the obstetric risk associated with maternal obesity. So just to impress you, this is the systematic review on the obstetric risk of maternal obesity. So these are very small prints. With my aging eyes, I can't really see it, so I try to enlarge it on this slide. So this is the busy summary of all those complications that can that will be raised in case of maternal obesity, including preeclampsia, gestational diabetes, thromboembolism, large for the gestation age baby, antepartum stillbirth, post-term delivery and preterm delivery, meconium aspiration, fetal distress, cesarean delivery, instrumental delivery, shoulder dystocia, postpartum hemorrhage, early neonatal death. Basically, if you take any obstetric textbook, you turn to the content page, right? All the rest in the content page of the book, you can find it here, right? And congenital birth defects is also related to preconceptual obesity, particularly for anencephaly, the neurotube defects, cardiac defects, and also diaphragmatic hernia and abdominal wall defects. These would be is reported with a significantly high odds ratio in obese women. Okay. So these are the adverse the effects of obesity on the obstetric outcomes. So that's why when we manage women with PCOS, the first line is to ask her to reduce weight. First of all, it may restore ovulation. Even if she can't totally restore her ovulation and she needs some further fertility treatment, she has better response to the treatment. And subsequently, when she gets pregnant, then we hope to reduce the subsequent obstetric risk. Yeah. On the other hand, obesity itself would also have the effect on metabolic phenotype. I think I can go through it pretty briefly because you know this better than I am as a metabolic physician. Now, so these are meta-analysis on women with PCOS who are overweight or obese, or for women who are actually obese with a BMI more than 30 or more than 25 in Asian studies. Okay, so this meta-analysis actually confirm our understanding that obesity is associated with lowered HDL, high total cholesterol, LDL, and triglyceride, high total testosterone, free androgen index, and low SHBG, and high fasting insulin and glucose, and worsening of the insulin resistance, and also a higher relative risk of dysglycemia. There's no significant effect on hirsutism though, and there's been no studies on the 2-OGTT in this regard. Okay. So obesity, particularly visceral obesity, actually is known to be a predictor of increased risk of the metabolic syndrome and the resulting long-term cardiovascular risk in this sort of women. So beyond fertility, I think this is still important to deal with the obesity for her long-term health. And in general, we do recommend regular monitoring of blood pressure, lipid profile, and glycemic state with the no GTT in overweight or obese women with PCOS. ที่ check 3 go 呢啲 And just the point to note is for women with PCOS, if we want to check for dysglycemia, we need a full OGTT, not just the fasting. In fact, there are quite a number of studies, including one done in my hospital, Queen Mary Hospital, in our cohort. In fact, if we just do a fasting glucose, we are missing half of the dysglycemias. More than half of the dysglycemia is actually having something wrong in the postprandial level rather than the fasting level. So we have to do a full OGTT.